is Steven.
Hello.
I'm from anesthesia,
Hi.
and we're going to ask you a couple of questions just to get you ready for your procedure today.
Okay, great.
All right?
Mhm.
Excellent. So first, can you tell me your name and your birthday?
My name is Ariane Safran,
Okay.
and my
perfect.
birthday is 6/3/87.
Excellent. It's nice to meet you, Ms. Safran.
Me too.
What are you here for today?
I'm here to have my appendix removed.
Okay. Excellent. Perfect. Do you have any allergies to foods, medications, other substances?
No, not that I'm aware
Not that
of.
you're aware of. Okay. Allergies. Are you taking any medications currently?
No, I'm not taking any medications.
No supplements, no herbal.
I do take a multivitamin.
Okay, excellent. Put that down. Great. So the next part of the assessment is going to be a system-wise health history. I've already asked the patient her name, her birthday, and why she's here as far as the central nervous system assessment goes. So first we're going to ask about your cardiac history.
Okay.
Do you have any issues with your heart that you're aware
No, not that I'm aware of.
of? Okay, excellent. No chest pain, shortness of breath, cough?
Mm-mm.
No.
No.
Okay, all right. Next we're going to talk about your lungs. Do you have any breathing issues that you know of?
No, not that I'm aware of.
Okay, no asthma, inhalers,
Mm-mm.
no, you don't use a machine at night to help you breathe?
Mm-mm.
Okay, all right. So next we're going to go over your gastrointestinal, so about your abdomen.
Okay.
Do you have any history involving your abdomen that you're aware of?
No, not that I'm aware of.
Any acid reflux, nausea, vomiting?
No.
Okay, all right. And next we're going to go over your endocrine system, so that goes over your hormones.
Okay.
Do you have any hormonal issues that you're aware of?
No.
Okay. Any thyroid problems, diabetes?
No, none of that.
Okay. All right, perfect. Next, we're going to discuss your kidneys. Do you have any kidney issues that you're aware of? Any problems urinating?
No,
Any other?
not that I can think
Okay,
of.
excellent. And next, we're going to discuss your musculoskeletal, so your muscles and your bones. Do you have any problems with ambulation? Any pain when you walk?
No.
No? Okay. All right. And any swelling that you've noticed in your lower extremities?
No.
No. Okay. Any ulcers, sores on your legs?
No.
Okay. So next we're going to discuss your blood. Have you ever been told that you have any kind of blood disorders, any clotting disorders?
No.
No.
No,
Okay.
I haven't.
You haven't noticed that you've had nosebleeds or been bleeding?
No, I haven't
Okay.
had any of that.
Excellent. Okay. Perfect. And next we're going to discuss your social history. Do you smoke?
I don't.
No. Okay. You've never smoked.
Never.
Okay. Perfect. How about alcohol? How much would you say that you drink every week?
Occasionally.
Okay.
Socially.
How many glasses every week would you say?
Maybe one.
One glass. Okay. All right. Perfect. And then, do you use any kind of drugs?
No.
No. Okay. No marijuana.
No.
Okay. All right. Excellent. Next, we're going to go over your surgical history. Have you ever had any surgeries before this?
I haven't.
No. Okay. All right. Have you ever had, maybe for a different procedure, have you ever had any anesthesia where you've gone to sleep with
No.
medications? Okay. Perfect. So no history of postoperative nausea and vomiting since the patient has never had anesthesia before. How about if any of your family members, have they ever had anesthesia?
They have. Yeah,
Okay.
several.
Any complications that you remember with the medications that they gave them to put them to sleep?
Not that
for
I
the
know
procedure?
of.
Okay, excellent. All right. So next, I've reviewed the patient's vital signs, including the patient's temperature, heart rate, respiratory rate, oxygen saturation, as well as the patient's intravenous access. She has an 18-gauge catheter in her right AC. I've also reviewed the patient's lab values, including her CBC, her chemistry, her electrolytes, as well as her coagulation studies. The patient has signed a consent for blood products, and her pregnancy test was negative. I've also reviewed the patient's EKG, her interpretation of sinus rhythm, her echocardiogram. Her ejection fraction was greater than 65%, and the patient did not have a stress test ordered. I'm going to do a focused anesthesia assessment on the patient. So, Ms. Safran, next I'm going to look in your mouth and just kind of check your neck range of motion.
Okay.
Okay, can you open your mouth for me? Okay, perfect. All right. Teeth look good. And when was the last time that you had anything to eat?
11 p.m. last night.
Okay, perfect. Perfect. Can you move your neck? Move it to the right and move it around. Okay. Excellent. And move it back. Okay, perfect. Thank you. So I was assessing the patient's neck range of motion as well as her thyromental distance. And her Mallampati classification based on her anatomy is A1. And based on the general assessment of the patient, her ASA classification would be a grade 1. We've completed the pre-anesthesia history of the patient. We're going to move on to the physical assessment. First, we're going to start with the cardiac assessment of the patient. We've already discussed that the patient does not have any cardiac history, the patient does not smoke, the patient is not obese, and she does not have a pacemaker or have coronary artery disease. So therefore, she does not have any risk factors for a cardiac event during surgery. During the exam, we're going to make sure that the patient is positioned appropriately, and I'm also going to explain everything that I'm doing to the patient before I do it. When using the stethoscope on the patient, I'm going to use the bell for lower pitched sounds, and I'm going to use the diaphragm of the stethoscope for higher pitched sounds. Lower pitched sounds would be things like murmurs, S3, S4, and higher pitched sounds would be S1 and S2. This portion of the physical assessment is going to be inspection of the patient's chest. Ms. Sofran, I'm just going to take a look at your chest while you breathe. So I'm noting the symmetry and the anterior-posterior diameter of the chest. When she breathes, everything appears symmetric, and I'm also looking at the precordium. I don't see any thrills as she's breathing. Next, I'm going to assess the right heart function by looking at her jugular vein. So I'm going to go to the patient's right side. Ms. Sofran, I'm just going to look at your jugular vein. If you could just turn your head to the left for me. So on inspection, the jugular vein is it's not visible. There's no pulsations and there's no swelling in that area. Next, we're going to proceed to the palpation portion of the exam. I'm just going to be touching your chest in a couple of areas to assess your heart function. First, we're going to assess the carotid arteries. So first, we're going to assess the left. Okay, pulse is present and regular, and the right. Pulse is also present and regular. Of course, we would not palpate both carotid arteries at the same time in order to preserve the blood flow to the brain. Next, we're going to palpate the point of maximum impulse of the patient's heart. I'm just going to be palpating your chest right down here to feel your pulse around your heart. So this is in the 5th intercostal space at the midclavicular line, and this pulse should be less than 1 centimeter in diameter or 1 finger breadth on the patient's chest. And next, we are going to palpate the patient's hepatojugular reflex. So I'm gonna actually have you lie down for me. Alright, so I'm going to be pressing on your abdomen, if that's okay. And if you can turn your head to the left for me. I'm just going to be looking at the vein in your neck while I palpate. So as I press down on the patient's liver, I am seeing that the jugular vein is becoming engorged with blood, and as I let go, I see that the jugular vein has, it's no longer engorged with blood. Okay, you can sit back up now, thank you. Okay, and next we're going to auscultate the patient's heartbeat. So I'm just going to be listening to your heart now with the stethoscope. And first I'm going to auscultate using the diaphragm of the stethoscope. First, we're going to listen to the patient's aortic valve, which is at the 2nd intercostal space at the right sternal border. Just breathe normally. Alright. And next, we're going to auscultate the pulmonic valve, which is at the left sternal border in the second intercostal space. All right. And next, we're going to auscultate the tricuspid valve, which is a little bit lower. It's on the fourth intercostal space at the left sternal border. All right. And finally, we're going to auscultate the mitral valve, which is a little bit lower in the fifth intercostal space at the midclavicular line. All right. Next, I'm going to count the patient's pulse. So her pulse is 70 beats per minute, and the rate is regular. And next we're going to auscultate for S1 and S2. S1 is best heard at the apex of the heart, which is at the lower portion of the heart. And then we're going to auscultate S2, which is at the top of the heart, or the base, also known as the base of the heart. Okay. And then we would auscultate for additional heart sounds, including S3 and S4. S3 is best heard at the apex of the heart, the bell of the stethoscope. Okay, so there's no S3 noted. And I've also previously listened for murmurs, and these are the result of this could be a result of a stenotic valve, which results in impeded opening, a narrowing of the vessel, or they could be the result of a non-compliant valve, a leaky valve, which is the result of insufficiency. Murmurs are scored on a scale of 1 to 6. Anything greater than 4, I would expect to see a thrill in the patient. And usually murmurs are the result of a left-sided heart problem. The next portion of the physical assessment for Ms. Sofran is going to be the vascular assessment. In the patient's history portion of the exam, she did not report any signs that would indicate a vascular problem. She didn't report any edema, she didn't report any lesions, she did not report any claudication while walking. So the first step in the vascular assessment is going to be assessing the patient's carotid arteries for a bruit, which would indicate turbulent blood flow. Ms. Sofran, I'm just going to go ahead and listen to your neck, the arteries in your neck, in order to make sure that the blood is flowing correctly.
Mm-hmm.
All right, so I would always use the bell of the stethoscope for this. And I don't hear any bruit in the left carotid. And there's no bruit in the right carotid artery either. All right, so next what I would do is assess the patient's upper extremities. Ms. Sofran, I'm just going to go ahead and look at your arms.
Mm-hmm.
So I would be assessing for color, temperature, as well as if there's any lesions present. Both of her upper extremities are symmetrical. There does not appear to be any edema present. And I'm also assessing her skin turgor. I'm just going to go ahead and pinch her skin very lightly. And this is going to be a measure of her hydration status. And the skin, after I pinch, the skin goes right back to its normal position in the left arm. And in the right arm, it does the same thing. So next, I'm going to go ahead and I'm going to assess her nail beds. I'm going to first assess for her capillary refill, which is an indication of her blood flow in her fingers. So I'm just going to go ahead and pinch your nail beds very lightly and check how fast the blood comes. So on the left side, the capillary refill is less than 2 seconds, which is normal. And on the right side, the capillary refill is also less than 2 seconds, which is normal. Next, I'm going to assess for clubbing, which would be an indication of some sort of cyanosis, some sort of disorder that would cause some sort of long-term cyanosis in the patient, which she did not report in her history. So to assess for clubbing, Ms. Sofran, I'm just going to look at your fingernails.
Okay.
I would expect the angle between the nail and the nail bed to be less than 180 degrees, which it is for Ms. Sofran. And on the right hand, the same is true. The angle between the fingernail and the nail bed is less than 180 degrees. So next I'm going to assess the patient's upper extremity pulses. So I'm just going to be feeling your pulses in your upper extremities, if that's okay.
Mm-hmm.
First, I would assess the brachial pulse. And pulses are graded on a scale from 0, which would be no pulse, to 4, which would be an extremely bounding pulse. And Ms. Sofran's brachial pulse in the right upper extremity is 2 and regular. Next, let's assess the right upper extremity, the brachial pulse. All right, that one is also 2 and regular. Now I'm going to assess your radial pulses. Those are both 2 and regular as well. So the next portion of the exam is going to be the assessment of the lower extremities. So Ms. Sofran, I'm just going to ask you to lie back for me, and I'm going to take a look at your legs.
Okay.
All right. So the patient's legs, I'm just looking to see if there is any edema, which there is not. She's not edematous. Both legs appear to be symmetrical. And there is no atrophy present in this patient. She's active independent, so I would not expect to find any atrophy. The color is the same in both legs. The temperature is warm. She has no lesions. And there is a similar hair distribution on both legs. So the next portion of the exam would be to feel for her, before we feel for your pulses, I'm just going to go ahead and measure your calf circumference. Okay? So I'm going to have you lift your left leg up for me. And then I'm just going to put my tape measure around her calf. And, okay, perfect. And then I'm just going to look at the other one, if you can do the same thing for me on the right leg. Perfect. Both measurements are within 1 centimeter of each other, which is a normal finding for this patient. Next, I'm going to go ahead and palpate her pulses in her lower extremity, using the same grading system as I used for the upper extremities. So first, I'm going to palpate the femoral pulse, which is 2 and regular, and let's see the right side, is also 2 and regular. Next pulse down is going to be the popliteal pulse. I'm just going to feel behind your... Okay, both those pulses are 2 and regular as well. Next, I would do the posterior tibial pulse, which is also 2 and regular in both extremities. And finally, the dorsalis pedis pulse, which is 2 and regular in both extremities as well. The next portion of the exam was the Hohmann sign, and if I were concerned that this patient would have swelling in one of these extremities, or if I was concerned about a DVT, a deep vein thrombosis, I would complete the Hohmann sign. So what I'm going to do for that, Ms. Sofran, if you could just lift your left leg up for me and then bend it at the knee, and then I'm going to dorsiflex her foot. And is there any pain in your calf when I do that?
Yeah.
Okay. So that's a negative Hohmann sign for the left leg. And I'm going to have you do the same thing with your right leg. And I'm going to dorsiflex your foot. Any pain in your calf?
Yeah.
No? Okay. So that's a negative Hohmann sign for both lower extremities. And if I was concerned about incompetent valves in her lower extremities, I could do the Trendelenburg leg raise test. And what that would involve is having the patient lie down, putting a tourniquet on the leg that I was concerned about, and then having the patient stand up and judging how fast the blood pools in her veins in the affected leg. If the affected leg pooled quickly, then I would be concerned about some sort of valve dysfunction in the veins of that leg. And I would order further tests which could include a ultrasound of that lower extremity. So for the next portion of the physical assessment on Ms. Sofran, we're going to assess her chest and breathing. So looking at the patient right now, she does not appear to be in any distress. Patient has normal and even respirations. She has a normal respiratory rate. She does not appear to be using any accessory muscles when she breathes. And the expansion of her chest and her back is symmetric when she takes a breath. Ms. Sofran, can you just take a nice deep breath for me? Again, her chest wall expansion is symmetric in the front. And one more deep breath. In the back, it's also symmetric when she takes a deep breath. So next I'm going to locate the suprasternal notch, which is correct in an anatomically correct position on her, and I'm going to locate the sternal angle. Okay, and I felt that in the correct anatomical position where the manubrium comes into contact with the top of the sternum. Next, I'm going to evaluate her for tactile fremitus in order to see if she has any consolidation in her lungs. So Ms. Sofran, if you could turn to your left for me.
Mm-hmm.
Every time, I want you to repeat the phrase 99 whenever you feel me touch your back. Okay.
99.
Okay.
99. 99.
Okay, perfect. So all the vibrations in all 6 areas that I've palpated were symmetric in as far as the vibrations, and she does not appear to have any areas of consolidation from this test. Next, I'm going to assess for her chest wall expansion using my thumbs around the area of the 10th thoracic vertebra. Ms. Sofran, if you can just take a nice deep breath in. Okay, and one more. Perfect. Okay, so when I'm doing this, I'm watching my thumbs come apart as she takes a deep breath and go back to the normal position when she exhales. And the normal distance between the thumbs for inspiration is 2 inches. Anything less than that, and I would suspect some sort of breathing disorder. Next, I'm going to percuss all of her lung fields. We're going to start with the posterior and her back. So I'm going to place my non-dominant hand on her back, and I'm going to tap on the intraphalangeal joint in order to assess the sound that I get from this. Just going to tap on your back.
Mm-hmm.
Okay, perfect. As I would expect, all of her fields are resonant, which I would expect for areas that are filled with air. If I were tapping over bone or areas of consolidation, I would expect it to be dull. Next, I'm going to assess her. I'm going to percuss her anterior chest. If you could turn around for me and face me. I'm just going to tap on the front of your chest, like I did with your back.
Mm-hmm.
Perfect. So as expected, all areas are resonant, which I would expect over areas that are filled with air. All right, next I'm going to go ahead and I'm going to listen to your lungs. We're going to start with your chest.
Mm-hmm.
Every time you feel my stethoscope on you, I want you to go ahead and take a nice deep breath in. Okay. Perfect. All lung fields are clear. I don't hear any crackles, wheezes, or any other adventitious breath sounds. You can turn around for me. And again, every time you feel my stethoscope on your back, I want you to take a nice deep breath.
Mm-hmm.
And final breath. Perfect. Again, lung fields are all clear. So the next step in the respiratory assessment is to assess the patient for vocal resonance using 3 different techniques: bronchophony, ergophony, and whispered pectoriliquy. For all these techniques, and for listening to breath sounds in general, I would use the diaphragm of my stethoscope in order to listen to the patient's lungs. So for bronchophony, that's the first vocal resonance assessment technique. I am going to have the patient repeat the word 99 as I put my stethoscope on her back. So Ms. Sofran, I'm going to ask you to repeat the word 99 each time you feel my stethoscope on your back.
Okay.
All right.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Perfect. So in all of the lung fields that I assessed, the words 99 were very muffled, which I would expect as a normal finding in this patient. If she had areas of consolidation, I would expect the 99 to become much clearer. The next portion of the exam is going to be ergophony, and I'm going to have the patient repeat the phrase E as I listen to her back again. So Ms. Sofran, every time you hear or you feel my stethoscope on your back, go ahead and say the phrase E.
Okay.
All right.
E, 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 E.
Perfect. So the patient, her lungs are very clear. I could not hear the E was not. If she had consolidation, I would expect the E to sound more like an A sound, which it did not. The final vocal resonance test is whispered pectoriliquy. And in order to do this test, I'm going to have the patient whisper the phrase 1, 2, 3. So Ms. Sofran, whenever you feel my stethoscope on your back, I want you to go ahead and whisper 1, 2, 3.
Okay.
All right?
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Perfect. So the sound was ineligible in all areas that I auscultated. And this concludes the respiratory assessment. So for the final portion of the physical assessment, I'm going to be assessing Ms. Sofran's neurologic status. We're going to start this assessment by asking some general questions in order to gain understanding of her current mentation. I just need you to tell me your name and your birthday.
Ariane Safran,
Okay.
6387.
Perfect. And where are you right now?
I'm in the hospital.
Okay. And what day is it currently?
It's on Monday.
Okay. And what are you here for today?
I'm having my appendix removed.
Perfect. So judging by the answers to these questions, we can tell that she is alert, oriented to herself, the situation, the time, and we can proceed to the next step in the assessment, which involves assessment of the cranial nerves. We're going to start with cranial nerves 3, 4, and 6, which are the ocular motor, the trochlear nerve, as well as the abducens nerve. By assessing her field of gaze using a pin, as well as the other aspects of the ocular motor nerve, including pupil constriction, dilation, as well as accommodation, and her ability to open and close her eyelids. All right, Ms. Sofran, I'm just going to ask you to look directly at my pen.
Mm-hmm.
And I want you to follow just the tip of the pen. I do not want you to move your head.
Okay.
All right? Follow the pen with your eyes.
Mm-hmm.
Perfect. Next, we're going to be assessing the patient's pupillary response. I'm just going to shine a light in your eyes, and I just want you to keep looking directly at the bridge of my nose. Perfect. Next, what I want you to do is I want you to look directly at the bridge of my nose, and then I want you to focus on, I'm going to ask you to focus on an object that's behind me.
Okay.
So stare at the bridge of my nose first, and then I want you to shift your focus to the tree that's behind me. Perfect. And then I need you to open and close your eyes for me. Excellent. So she was able, her pupils would constrict in response to the light, and she, in both eyes, and she was able to look directly at the bridge of my nose, and her pupils would also constrict. When she focused on the object that was far away, her pupils dilated in response to the increased distance that she had to see. And she was also able to open and close her eyes, so her ocular motor nerve is functional. The next cranial nerve that we're going to be assessing is cranial nerve number 5, which is the trigeminal nerve. In order to assess the motor function of this nerve, I'm going to ask the patient to clench her jaw, and in order to assess the sensory function of this nerve, I'm going to be using either a pen or a cotton ball to touch various parts of the patient's face, and with her eyes closed, I'm going to ask the patient to describe the sensation that she feels as either soft or sharp. So what I need you to do first, Ms. Sofran, I just need you to clench your jaw for me and show me your teeth. Perfect. And I can feel the muscles contracting in her face as she does this, which is a normal response. Alright, so next what I'm going to do is I'm going to ask you to close your eyes, and I'm going to be touching various parts of your face with either the tip of this pen or with this cotton ball, and I want you to tell me if the sensation you feel is either soft or sharp when I touch your face.
Okay. Sharp. Soft. Soft. Sharp. Sharp. Soft.
Perfect. You can go ahead and open your eyes now. The next cranial nerve that we're going to be assessing is cranial nerve number 7, which is the facial nerve. In order to test this nerve, I'm going to ask the patient to wrinkle her forehead and close her eyes as tight as she can.
Okay.
All right. So I just need you to close your eyes as tight as you can for me, and then can you wrinkle your forehead? Excellent. Perfect. Both of these are a normal response to assessment of this nerve. The next nerve we're going to be assessing is cranial nerve number 8, which is the acoustic nerve. In order to do this, I'm going to be assessing each ear and make sure that she can hear the phrase that I'm saying. All right, Ms. Sofran, so what I'm going to do for this is I'm going to ask you to close your eyes, and then I'm going to whisper a word, and I want you to tell me what you hear.
Okay. Apple.
Yes.
99.
Perfect. She was able to correctly identify both the phrases that I said in either ear. Next, what we're going to be assessing are cranial nerves number 9 and number 10, which are the vagus nerve as well as the hypoglossal nerve. I'm not actually going to assess this on this patient, but in order to assess both these nerves, I would use a tongue depressor and touch the posterior aspect of her pharynx in order to elicit a gag response, and that would be the normal response to stimulation of this nerve. Next, we're going to assess cranial nerve 11, which is the spinal accessory nerve, and I'll do this by simply asking the patient to shrug her shoulders to assess the motor response of the various muscles that are innervated by this nerve. So what I need you to do is just go ahead and shrug your shoulders. Excellent. And go ahead and relax. Perfect. The final cranial nerve number 12, the hypoglossal nerve, is going to be assessed by asking the patient to move her tongue into various positions. Okay, Ms. Sofran, I just need you to stick your tongue out and move it to the right and to the left. Perfect. So the patient was able to move her tongue into the various positions that I asked her to. The next portion of the neurologic assessment is going to be to assess the patient's sensory function in her 4 extremities. We're going to start with assessment in the bilateral arms as well as the bilateral hands. All right. Okay, Ms. Sofran, I just need you to close your eyes, and then I'm going to be using the same tools as earlier for the assessment, and I'm going to need you to say if the sensation that you feel is either sharp or soft.
Okay. Sharp. Soft. Soft. Sharp.
Perfect. You can go ahead and open your eyes now. Next, we're going to be assessing the patient's lower extremities in the same fashion. Okay, Ms. Sofran, I'm going to be doing the same thing to your calves, to your ankles, and to your feet.
Okay.
I just need you to close your eyes,
Okay.
and I need you to tell me exactly what kind of sensation you feel, whether it's sharp or soft.
Okay.
All right.
Sharp. Soft. Sharp. Sharp. Soft. Soft.
Perfect. You can go ahead and open your eyes now. So the next portion of the exam is going to be assessing the patient's position sense. To do this, I'm going to be using her fingers and her toes, and I'm going to be moving, with her eyes closed, I'm going to be moving them up and down, and I'm going to be asking her what direction I'm moving them in. So we'll start with your hands.
Okay.
So go ahead and close your eyes. And let's put your hands out. Okay. So now I'm going to be moving your fingers,
Okay.
and I want you to tell me if I'm going up or down.
Okay. Up. Down. Up. Down.
Perfect. You can go ahead and open your eyes. Next, we're going to be doing the same thing with her toes. All right, so we're going to be doing the same procedure with your toes. I just want you to keep your eyes closed and tell me if I'm moving your big toe up or down.
Okay. Up. Down. Up. Down.
Perfect. You can go ahead and open your eyes. So this concludes the neurologic assessment as well as the head-to-toe assessment in general for the preoperative patient.